So moving on to part 3. I accidentally got cut off there. So intraspinal delivery, epidural space, that's the epidural. Subarachnoid space is intrathecal. Intermittent bolus or a continuous infusion. Some complications of intraspinal analgesia could include the catheter becomes displaced, accidental infusion of a neurotoxic agent, epidural hematomas, as well as an infection. I've taken care of numerous patients who have had surgery, and a lot of times in the past, doctors would order epidurals, but the only problem is if they're getting a high dose of it, or even like the normal range of the dose, their legs, they still feel numb. And a lot of times I've had patients where you have to titrate that dose down so they can get up and walk postoperatively. Patient-controlled analgesia, the PCA. So with this, the dose of the opioid is delivered when the patient decides a dose is needed. And of course, the patient just pushes that button in order to deliver the bolus. It's often used for acute pain, such as post-op, cancer pain. Often morphine and hydromorphone or Dilaudid is used. You need to teach the patient that they cannot overdose. Now, also on a PCA, the doctor can order a continuous infusion, maybe 1 milligram per hour, and then possibly they may order bolus PRN doses every so often, so if the patient is still in a lot of pain, they can push that button. But the thing that you have to remember is the patient's respiratory rate. That's your highest priority of care with the patient with PCA due to that respiratory depression. So I'm going to skip over some slides here on interventional therapies, non-drug therapy, other things that can be done, massage. Typically, if a patient's going to have a massage done, maybe they're having some back pain, a very light massage, nothing too deep, because that could make the pain worse. Of course, physical therapy, they can teach the patient strengthening exercises. There's a TENS unit. I mentioned the acupuncture as well as hot and cold. So with the TENS unit, so the system consists of 2 or more electrodes connected by lead wires to a small battery-operated stimulator. Patients have had good effect with that, and of course, you turn the page, you can see the TENS treatment there. Cognitive therapies, there's also hypnosis. Patients can download apps from their phone and listen to those. The strategies work by affecting the perception of pain. So cognitive theories that affect the perception of pain by the brain rather than affecting the efferent or afferent pathways, or influencing the release of chemical neurotransmitters in that dorsal horn. So with nursing interprofessional management, if a patient says they're in pain, they're in pain. Don't think that they're just sitting there and complaining or making this up. Some common concerns, obviously tolerance, addiction, those are the big ones. So with barriers to effective pain management, you need to remember the goal is to reduce the amount of medication and at the same time minimize adverse and withdrawal effects. With pseudo addiction, this problem, it can be avoided by effective communication strategies and optimal pain management. Addiction, the hallmarks of addiction include compulsive use, loss of control of use, and continued use despite risk of harm. Ethical issues, requests for assisted suicide. You may take care of a hospice patient in the hospital, and also hospice can be consulted as well. I've taken care of patients who are end of life care, and a lot of times you have families who maybe the patient's getting a morphine drip and they'll just ask, well, can't you just increase it to, put them out of their misery? When you want, the whole goal is to keep the patient comfortable. And obviously you can't increase the drip just because the family, wants this to end. Obviously that's euthanasia. And of course, with your geriatric patients, always remember that older adults, they typically have more chronic complaint problems. And let's see, so I'm going to skip over the rest of the geriatric, and that's pretty much the end with this lecture. So our next lecture will be end of life care. Thanks.